So today I am super excited because I have a friend of mine who we trained together at the University of Miami, Jackson Memorial Hospital, and this is a topic that interests everyone. And I am super excited to invite Dr. Wallace here, who's an internationally recognized neurologist and sleep specialist based in Miami. He serves as Associate Professor of Clinical Neurology at the University of Miami School of Medicine and is the Medical Director at the Sleep Center at the Miami VA Healthcare System. Dr. Wallace's clinical practice research focuses on treating insomnia and sleep disorders, especially in veterans, together with complex overlap of obstructive sleep apnea. He also studies common conditions in military populations that interfere with sleep health and with adherence to treatments like CPAP and cognitive behavioral therapy and insomnia. And I am super excited for Dr. Wallace, Doug, to be here. And we have to catch up. Obviously, we'll do it off the air. But it's been a long time since we see each other. And by looking at you, you look exactly the same. It's amazing that we can sit and have a conversation about neurology and sleep. Thank you for coming.
Really excited to be here. Thanks so much for inviting me. It's crazy, but we only live 3 miles apart. That's how long it took me to get from my house to yours.
So we're going to have a conversation, and I think it's going to be so interesting because you and I, this is the thing about you and I, are very much relatable humans that just can chill, talk to everybody, and so people can understand what it's like in medicine and sleep and health. And you and I definitely share a lot of things in common, especially during our residency, on how we approach patients. So that's why I wanted to bring you here. Let's talk about, just very briefly, and then we're going to get into all the questions about myths about sleep. One of the questions I have for you is, why did you decide to, when we both went to neurology, why did you decide sleep?
Yeah, that's a great question. After we finished our residency in neurology, I kind of realized, number one, I knew very little about sleep. And number two, as you may recall, we spent a lot of sleepless nights at Jackson. And all that sleep deprivation definitely had a very profound effect on me, like how I felt, my cognitive function, my mood. And I thought to myself, like, if it had that big of an impact on me, it must certainly be impacting the patients that we care for, right?
But isn't it amazing, Doug, that we spend our whole lives through education, and then we're doctors, and then we get trained in neurology, and we could probably name every single neurological condition. But then when it comes to sleep, which is so common, so many people just don't know anything about sleep. Is that right? I mean...
Yeah, I think you're right. For a long time, we didn't get a lot of sleep in medical education, whether that's in medical school or during residency. It's changed somewhat. It has changed. People are recognizing the importance of sleep and the importance between sleep and health, right? And wellness, particular. So much of what I do, to a certain extent, is be people's life coach to a certain extent, because obviously what happens during the day impacts your night, and of course we all know that your nighttime impacts your day, right?
It's amazing because when I was a resident, I remember not sleeping. They do have changed the laws, so we which is appropriate because we really were sleep deficient. We made decisions sleep deficient. I remember working the next day without even sleeping, but I kind of got used to it, and I kind of got used to feeling kind of slow and making decisions slow, and it was kind of normal to me. And then it also made me a better sleeper somewhat, being used to being deficient in sleep. What is it about sleep and your cognition? What do you feel the importance of sleep and cognition that we don't know, that you can teach people?
Well, sleep is vital for your memory function, right? We kind of know that there are some very important things that happen in your brain while we sleep, right? For example, all the new information that you put on your desktop, if you will, gets transferred into your hard drive during sleep. So we've all experienced that event where you sort of pulled an all-nighter, maybe after a huge test, right? You took the test, you never went to sleep, and then all that information was wiped off your desktop because you never went to sleep. So if you think about it, while you're investing in your education and investing all this new stuff that you're learning, if you don't get the right kind of sleep, you never hold on to that new information.
So you're downloading your memories and downloading information with sleep itself. So let's get into the sleep things that you hear, which I hear all the time when we discuss this, is the insomnia and sleep deficiency with families and the stigma. It's normal. Describe to me what we were talking about before off the air regarding those concepts.
I think the ability to recognize whether you have a sleep disorder in the first place, right? Uh-huh. We basically define a sleep disorder by having sleep complaints that are associated with daytime impairments or daytime deficits. And those deficits can be quite broad, everything from feeling fatigued to feeling sleepy to feeling irritable to calling out sick from your work because you didn't sleep well the night before, and just not working at your best. Right.
But normalizing sleep. So like you said, some people are normalize insomnia, like it's normal. Is that correct?
Yeah. I mean, a lot of times people start to believe, since I've had this sleep problem for 10, 20, 30 years, that's just normal for me. And they kind of even stop complaining about it, right? Or perhaps if there's several family members in your family who have the same sleep complaint, for example, snoring or insomnia, you can normalize that sleep issue, right? And maybe not get the help that you really need.
But do you think it's genetics? Do you think insomnia is genetic? Not some of the genetic conditions of those parasomnias, but like insomnia itself. Do you think it's genetic?
To a certain extent, yes. There's a model of why people get insomnia called the 3P model, which essentially says that people are predisposed to getting insomnia. So people who have a subclinical level of anxiety, for example. Then there's like a precipitating factor or something that starts the insomnia. It's usually like a bad life event, like a divorce, an illness, a death. Right? And then perpetuating factors or things that keep the insomnia going after the initial life event has been, has passed. So those perpetuating factors can be things like now you're having to drink a lot of coffee, take daytime naps if you're really tired from your sleep loss. And you develop a lot of also psychological responses to that sleep loss, right? People develop a lot of performance anxiety about their sleep. You're really worried about your sleep.
Yes.
And then you can work yourself up into a tizzy at night. And then it's a self-fulfilling prophecy, right?
That is so common, Doug, that's one of the things I talk about is that patients come in and they are desperate to sleep. And the things they do that they think are helping them sleep actually makes the problem louder and louder, which makes it more difficult to sleep. So let's say somebody wants to go to sleep at a certain time. Now, we're not going to get into that because I want to ask you that question. But let's say they want to go to a specific time and they are saying, okay, we're going to go to bed at 11. And then they close their eyes and then their mind starts racing about things. And I hope I get to sleep at night. If I don't sleep tonight and tomorrow I have all this project to do, then I need to sleep, right? So then the brain is saying that I need to sleep as opposed to I get to sleep. And then should I take my medication such as, let's say, Zolpidem or Benadryl or whatever it is? Maybe I should take it tonight. Maybe I should take it tomorrow. Maybe if I wake up again, I should take it. So then again, more preloading, more the brain itself becoming louder and louder and louder. So let me ask you a question with this because I want to get into that. Let me ask you, where do you begin with a patient who has all of these complaints and just wants to get to the bottom of it, is to sleep? Do patients, this is a bunch of questions I'm asking, but let me ask you question number one. How do you approach a patient who has insomnia, which you think is related to, let's say, anxiety or their brains can't turn off? Let's start off with that.
Yeah. So as you may know, the first line therapy for insomnia is something called cognitive behavioral therapy for insomnia, CBT-I.
Okay.
Right? And CBT-I is a behavioral intervention which attacks unhelpful thoughts about sleep.
Okay.
Right? Unhelpful sleep practices, right? So people who nap, get into bed way too early, right? And so we sort of put people on a schedule that sort of aligns with your internal body clock.
Okay.
And essentially that program makes you sleep deprived initially, and then you open it up. But it also attacks these unhelpful thoughts that drive the insomnia. So there's a lot of cognitive reframing, and that is done through challenging these sleep beliefs that are unhelpful.
Okay, so but you just said the sleep deprivation. So in the beginning, sleep deprivation. So do patients get really nervous about that word sleep deprivation, that I'm actually not going to sleep in the beginning?
Well, we frame it as you feel a little feeling worse is part of getting better.
But it doesn't, and it's amazing because patients are so concerned about sleep deprivation, yet they're coming to you because they're not sleeping anyway. Is that correct? So, right? So I'm saying they're coming in because I can't sleep, but then you're getting into these patterns where you're actually going to work on getting them to sleep. They get a little nervous about that, which excites it a little bit more. Is that correct?
Well, what happens with insomnia is that not every single night is a bad night, right? Is a bad pattern of sleeping, right? So you may have 2 bad nights, a good one, 3 bad nights, a good one. It's very erratic, right? And that's part of the issue with insomnia. People feel helpless.
Totally helpless.
And that your sleep is totally out of control, right? So what this cognitive behavioral therapy does is that it gives you a set of tools to have control over your sleep. If you think about the most common way that we treat insomnia in the United States, right? That's prescribing medications.
Yes.
And what a prescription really does, what a sleep aid gives you, is control over your sleep, right? I can take that sleeping pill tonight and I know that it will put me to sleep. Well, it gives you a sense of control over your sleep.
A sense of control. So do you think by giving a patient control over their sleep, that will help them?
I think giving them tools
to help. Okay.
Is really helpful, right? To use an analogy would be like getting someone who's totally out of shape, maybe giving them a personal trainer, hiring a personal trainer who shows you how to get back into shape, and then you can do it yourself.
Right. So let me. That's a good thought. So let me ask you: when patients come in and see you, right? Do they expect to sleep? I mean, for me, they expect by you giving advice or medication that they're going to sleep probably within a week. Right. How do you give them expectations that, like you said, with a trainer, you're not going to look a certain way unless you start.
I use the same analogy with people with insomnia, right? You don't get into shape like that, right? And you have to do a lot of little things to get into shape. You have to work on your nutrition, work on your sleep, obviously do exercises. The same thing with improving your insomnia. You have to target a lot of little things.
Yes.
And these small changes sum to improving your sleep slowly over time, right? Just like your sleep didn't go from great to crappy, right, in a few nights. It's also not going to unwind itself in the same way, right? We all have bad nights of sleep. That's just a normal part of life.
Yes.
Right. So once in a while, you might have a bad night of sleep and it's not that big of a deal, right? But a lot of people need to work with a therapist. Usually back in the day, a clinical psychologist used to do this cognitive behavioral therapy, and it was quite expensive. You'd have to go 6 to 8 sessions for an hour.
Right.
And again, very costly. Now there's a lot of apps that you can actually do cognitive behavioral therapy on your phone, at your own time, and it's quite reasonable. It might be like $9 a month, $20 a month, and you do it for a couple of months, and your insomnia will improve incredibly. But going back to what are the expectations that people have?
Yep.
One of the initial conversations that we have is, what have you tried in the past?
Sure.
Right? What are you expecting out of this appointment? And how would you like to fix your sleep? The reason that you don't have insomnia is not because you have an ambient deficiency.
Right.
It usually has to do with stresses in your life. What are the coping strategies that you use to manage that stress? Are those healthy ways of coping or not? Let's explore that, and let's see perhaps what are other coping strategies that I can recommend to you that we know works. So for example, exercise is a very common way that we can improve people's sleep. The best data for exercises that actually improve insomnia are jogging, yoga, and the last one is Tai Chi.
Okay. So, let's get into that. Well, what percentage, just roughly, how many patients would actually adhere to a sleep schedule by you? Like that's the thing, is that it's like going to the, you gave a good example so that maybe people can relate to the gym because they think sleep is a sleep deficiency and it's a medical problem. When you go to the gym, people that don't adhere to gym, as far as going to the gym at a certain time and working out to failure. So I believe that in life you have to fail in order to succeed. So at times you have to fail, succeed. Also, the mindset's so important in the gym because, yes, you got to push yourself at times to get stronger and stronger and stronger. That's the gym. It's the same thing. But in the sleep world, it becomes a completely different thing because there's a stigma that the doctor is going to prescribe medication, right?
Yeah. I think by the time people come to speak to someone like me, they've already tried several sleep medications, right? So you're here to try something new. You tried to fix it this other way and it didn't work.
Right.
So why not try it my way or this other way that you haven't tried? Now, what you're asking though is that these approaches with cognitive behavioral therapy for insomnia is difficult. It is challenging, right? Mm-hmm. So studies have shown that about 40% of patients are able to adhere to all the recommendations, right? Sometimes they want to do some of them, but not other ones, okay? So for example, part of this cognitive behavioral therapy for insomnia is something called stimulus control, which is relearning that your bed is just for sleep. So when people spend a lot of sleepless nights in their bedrooms, this becomes like a torture chamber. And you have a lot of negative emotion that's attached to that bedroom environment.
Yes.
So we have to reteach your brain, right, that environment is just for sleep. So we tell you don't go to sleep or don't go to your bed until you're very sleepy. Even that if that's 2 o'clock in the morning, 3 o'clock in the, that's okay, you know? So you have to sort of relearn or reteach your brain to listen to these cues, right? And go to bed when your body and your mind tells you that it's time for you to go to bed.
I love that. I do love that. I just feel that the community, and this is why I want to bring you on here, is that I feel like you're battling a lot of social media stigma and myths and beliefs that are told to a lot of people on sleep, and there's something wrong with them, and it's a condition, and it's not a secondary condition. Insomnia is a symptom related to other things.
Yeah, so I think what you're getting at is that insomnia can be comorbid with a lot of different conditions, right? So back in the day, like in the 60s, when people used to show up to their primary care physician with chronic insomnia, they used to be told, you're depressed, so I'm going to give you an antidepressant. Right? So this was actually thought to be latent depression. We know that that's not true. There's a lot of bidirectional relationships between some of these comorbidities and insomnia, like anxiety, depression, right? These people who suffer from anxiety and depression, insomnia is a symptom of those conditions, but having protracted insomnia also causes relapses or worsening of anxiety and depression. So insomnia is not only a symptom, but it's also a risk factor for those conditions as well. Same thing with like people who have chronic pain, right? If you have a lot of orthopedic issues like shoulder pain, neck pain, back pain, you obviously have difficulty getting comfortable in your bed, and that leads to a lot of insomnia. And we have to treat or manage those comorbid conditions for your insomnia to improve. But managing those conditions alone does not actually improve the insomnia. And that's why insomnia needs its own independent treatment.
I love it. And, you know, it's amazing talking to neurologists because typically insomnia is treated with psychiatry, general medicine, the general doctor. And sometimes it's, to me, what's the pathway to see a neurologist? Because I feel like people don't really recognize that neurologists treat insomnia. It's for you because you're a subspecialist. But as far as me as a neurologist, I'm seeing insomnia because I'm asking the questions whether they're sleeping because their migraines are out of hand or other things that are going on. There's not a day in my practice that I see sleep difficulties related to a neurological condition.
Yeah.
So what's the pathway for somebody to see you? Like, so because typically a pulmonologist, right, for sleep apnea,
Right.
but you do it all, right? Is that correct? So what is the pathway to see a neurologist?
So, I mean, usually you can either self-refer or the other neurologist refer to us, right? So I do see a lot of patients who have comorbid other neurological conditions, epilepsy, Parkinson's, et cetera. But you can just, go directly to the sleep clinic self-referral. Yeah.
All right, so let's talk about sleep. I have a lot of questions for you about sleep. I'm sure everybody wants to know about these questions. So I'm going to start off with just questions, and hopefully you can just answer them. And if you feel to just elaborate. All right, so 8 hours, right? So people say 8 hours is the number. Is 8 hours the number?
So in adults, we recommend 7 to 9.
Okay.
Right? And it's a normally distributed curve. That basically means that 2.5% of people need more than 9 hours, and that's normal for them. And that 2.5% of people need less than 7.
Okay, so how about people that say that they function with 4 hours?
Yeah, that's probably not true.
Not
right?
true.
People tend to also sort of underreport the real like hours of sleep. And we see this in the sleep lab all the time. We have people who we have them hooked up to their brain waves. We know exactly how much sleep they get. When we ask them, how many hours of sleep do you think you got? They'll say things like 2 or 3, but in reality, sometimes it's 4, 5, 6. So there is a little bit of inability to tell how many hours of sleep you actually get. And we've all had this phenomenon, right? That in the early morning hours, maybe you wake up, you kind of look at your watch, you fall back to sleep, and then you wake up later, and you could swear that you were actually awake the whole time, right? But in reality, you get a lot of micro sleep.
So that's something that is very important, because a lot of patients say, I don't sleep at all.
Right.
And you have evidence that they're sleeping, even though they're saying they're not sleeping. All right, I'm going to be bouncing back and forth. How about snoozing? What is snoozing good?
Well, it depends, right? We don't want you to snooze in general, because then that sleep that you get after the snooze is pretty light and pretty poor, right? But it could indicate that if you're waking up feeling that sleepy, you're either getting insufficient hours of sleep or not the right kind of sleep, right? So when we do speak about sleep health, we all are familiar with hours of sleep or duration of sleep, right? But sleep happens in multiple domains, right? The timing of your sleep, when you actually get those 7 to 9 hours, is very important. The other thing is the variability of your sleep, right? We don't want those 7 hours to be 7 different hours every single day. We want them to be phase locked. You can think of sleep duration as a dose of a medication. You want that dose to be steady across the entire week, right? What happens to most people is that we are all sleep deprived on our work days, right? And we try to catch up with
That was my next question. Yes.
Yeah, with that sleep duration on the weekends. And we call this social jet lag, right? And social jet lag is basically the idea that your wake up time on your non-working days is 3 hours later than on your working days. So for example, if I wake up at 6 a.m. on my working days, on my weekends, I wake up at 10 a.m. And we know that having this social jet lag is associated with a lot of health consequences, like gaining weight, even high blood pressure and cardiac disease, right? It's similar to you taking a red eye to LA every Friday night and then trying to come back on that red eye on Sunday. So it's not surprising that then people can't fall asleep on Sunday night or start or feel terrible on Monday and Tuesday.
Well, yes. And I could just tell you that I take sleep seriously, although I am sleep deprived because I've been taking so much call. I can tell you that when Friday hits, it gets to a point that I'm super tired. I can feel my eyes, even at a stoplight, get really, really tired, that I could fall asleep. And that's pretty bad. And then I use the weekends when I'm not on call to catch up.
Yeah.
So I could definitely relate to that. And then, I want to put exercise, all these things. So I preload myself. But I sleep very well, but I don't sleep efficiently. Is that correct?
Right. it depends on you. Do you wake up feeling refreshed, right? Because your sleep should be refreshing. So the quality of the sleep is another domain that should be.
So that was my next question. Is that I have patients and people say when they wake up, they feel refreshed and they only sleep 4 or 5 hours, and then they feel is that okay?
Yeah, I mean, the most important thing is how you feel during the day. Like if you feel that you're on your best, you're not sleepy, you're not grouchy, your cognitive thinking is clear, you're sharp, you likely may not have daytime impairment, right? So that person may not be getting that little sleep. They may be getting more sleep than they're kind of reporting to you, right? So that may be another possibility. But we really care more about the daytime impairments, because if you don't have complaints of daytime deficits, then you don't really have a sleep problem, right? Sometimes you get someone who will say like, it takes me an hour to fall asleep, but then I get 7 hours of sleep and I wake up feeling totally fine. And that person doesn't really have insomnia because they don't have any kind of daytime deficit. They don't have any consequences of that complaint.
But a lot of times as my brain is stimulated a lot, let's say, and then if I sit on a couch right after work, I can easily fall asleep in 2 seconds. So I don't know.
Then you're sleepy. Then you're functionally sleepy, right?
Yes.
Sleepiness is really interesting for people who are chronically sleep deprived. You kind of mentioned when we were on call and always sleepy.
Yes.
There is this plateau. We've done experiments where you take normal sleepers and you only let them sleep 4 or 5 hours every night, and you ask them in the morning, how sleepy do you feel? They lose the ability they don't continue to say that they're sleepier and sleepier. But when you test them objectively with reflexes and driving simulations, they perform poorer and poorer and poorer. They continue to do worse on objective testing, but they're not able to judge themselves how sleepy they are.
Absolutely. Absolutely. And I could tell that when I sleep well, I am on fire. My brain is working so well. Mm-hmm. But then again, this is what happens, right? So what happens to a lot of people is that we normalize insomnia and feeling sleepy because that we're working and we need to be working, and sleep is, sometimes not is losing the information overload of the world. So if you're sleeping, you're not participating in the social activities and life itself. So what I'm getting at is that we start then relying ourselves on stimulants. Now, it is amazing to me because in the medical world and then patients coming in, I mean, coffee in Miami, Cuban coffee, of course, plus the energy drinks and energy drinks at clubs and mixed drinks and all that stuff. And then even the use of Adderall and amphetamines and all of these things. I think we're fighting this condition of insomnia with all this stuff. So let's get into a little bit of stimulants. I love coffee and coffee tastes great. We cut it at a certain times during the day. Let's talk about stimulants itself. Is there a role for coffee or caffeine? Let's say caffeine products.
Well, it's okay in the morning. Right? We usually don't recommend it after lunch.
Okay.
There are some genetic predisposition to how quickly you may metabolize it, right? There's a lot of people who tell you, I have coffee at 7 p.m. and it doesn't bother me. It doesn't impact me in any way, shape, or form.
I'm Latin and I can drink and then go to sleep at night. That's what I hear. Yes.
Right. So we still kind of try to get them off of it regardless. So in general, though, if you're having to rely on that much coffee to get you through your day, we really have to do a deep dive on why that is the case, right? And whether you're just not getting enough sleep or not the right kind of sleep. So you may need an evaluation because at some point you're just going to crash, right?
Right.
Figuratively or objectively.
So So you say cut it out now? What is it? The coffee? It's the adenosine. What explain just briefly about stimulants and coffee affecting sleep?
Right. So it's a adenosine receptor blocker. Right. So adenosine is basically a substance in the front part of your brain that builds up. The longer that you're awake, the more adenosine that there is in the front part of your brain, which forces you to try to go to sleep. And it's something that we call homeostatic sleep drive. And you can think of it almost like waking up, putting on a backpack, which is empty in the morning. And the longer that you're awake, you're putting stones into the backpack.
Oh,
right?
Lovely.
And then at night, that backpack is really, really heavy, and you should be able to go to sleep very easily. And that's why if you take a nap in the afternoon, you're unloading that backpack. And that night, you'll be able to go to sleep much, much later than you might typically.
All right. Now this is a very interesting. I'm giving you a lot of examples of my patients and what they ask me about. Two parts of this question that interest me. One is, I fall asleep at night, but I can't stay asleep. Mm-hmm. Okay. And then the second part, which is kind of connected, is I've always been a light sleeper. I don't think I get into my deep stages of sleep. So let's start off with that first part, is that I fall asleep and then it could be 15 minutes, 1 hour, 2 hours. I can't go back to sleep. How do you approach, or what is the approach that you use for that type of patient? I know it's in general, because everybody's different.
Yeah, of course.
But it's a common complaint. Yes.
We do a whole assessment of
right.
What time are you getting to bed? How much time do you spend in bed? Are there other disruptors of your sleep? Some more obvious than others, right? Mm-hmm. We talk about sleeping environments, right? Okay. Are there things in your bedroom, in your house that are disrupting your sleep? Whether that's light, noise, your bed partner. Does your bed partner snore?
Sure.
Is that messing up your sleep? Do you snore? Could you have sleep apnea? Could a breathing problem be waking you up at night, right? Sometimes people sleep alone, and that may be harder to judge, right? So sometimes we have a lower threshold for doing sleep studies in someone like with this kind of complaint.
So that's my next question, is that light sleeping, deep sleep. How does a patient know if they're getting the stages of sleep? Can you describe very briefly the stages of sleep?
Right. So we all sleep in 90-minute cycles of sleep, right? Usually you go through the lighter stages of sleep, deeper sleep in the first 3 hours of your sleep cycle. Each sleep cycle ends with a little bit of REM sleep. And the closer you get to morning time, the more relative time that you spend in REM sleep. So 4, 5, 6 o'clock in the morning, more than half of that time of your sleep can be in REM sleep. And when you wake up in the middle of that REM sleep, you remember your dreams, right? There are some people who just never remember their dreams because they don't wake up in the middle of their REM cycle, but that doesn't mean necessarily that they don't sleep or that they don't dream, sorry.
So how do they know if they're going, because again, patients say that they sleep a few hours, they sleep more. Then they say that I don't get into my REM sleep. And is it possible that they are getting into REM sleep?
It's possible, yes. They might mean they don't remember their dreams. And sometimes that can happen if your sleep times are more variable, for example. But there are some conditions that prevent you from getting into REM sleep, like having untreated sleep apnea. Because sleep apnea, which is basically collapsing of your upper airway tissues while you sleep, there is normal physiology that should happen during REM sleep. That is that your all your muscles are paralyzed. So if you're already snoring and these upper airway muscles are falling, during REM sleep, they fall a lot more. And a person with untreated sleep apnea often is not able to go into REM sleep. So those people may not be getting any REM sleep at all.
Okay, so let's go back what you said before. I love the fact you said environment. So we didn't even get into that. So there's so much to talk about, and I'm so happy that you're here. And I'm sure everyone's going to be excited to listen to this. So let's talk about the environment, because I think people poo-poo it, or they say they do it all. And so let's talk about, how does your brain know it's time to sleep? What are the things that you suggest to your patients about habits and hygiene?
Yeah. So you have to remember that one of the main cues for your brain to start making melatonin is darkness, right? So that's why we always talk about not exposing yourself to electronics, having sort of night mode on and all your technological things, and putting the technological things away at a certain time, usually like 2 or 3 hours before bedtime.
2 to 3 hours. Can you imagine?
And we even suggest that you start sort of dimming the lights in your house if you can, to start telling your brain that you're nearing the time for bed, right?
Okay.
So it's not only about setting the physical environment, but also sort of the mindset to go to sleep, right? So physically sort of toning down the level of activity, but also intellectually, your brain activity, we have to tone down the level of activity closer to bedtime. So making sure that you're not watching things that are going to get you too upset, the news or movies that are too sort of distressing, right? Then we kind of talk about the bedroom environment. You just want to make sure that your bedroom is cold, right? We know that the optimal sleeping temperature is 68 degrees, which is quite cold, right?
That is quite cold.
Yeah. You want to kind of hibernate a little bit.
But that's a battle with partners on 68 degrees. Okay. So 68 degrees. Okay. How about showers? Cold showers, warm showers?
Yeah, hot showers.
Hot showers.
Yeah, because when your body is cooling, it actually induces sleepiness, right? So we suggest hot showers before bed.
Okay. Keep going. This is very good.
So the environment, you just have to make sure that there are no other disruptors like light intrusion, right? You can use face masks eye masks to sleep. Also, if you do have a bed partner, or sometimes people sleep with their pets or other, let's say kids in the bedroom, you can use earplugs too. That's something that it's relatively easy to do that people can try.
Do you think sometimes, because I have people say, I do all the right things with sleep hygiene, but they overload themselves to a point where it's like so rigid that it makes them more anxious?
Exactly.
So they'll throw in, they'll cover the eyes with a mask, cover mask. They'll make sure no sound. Yeah. They'll blacken the shade, and then it gets to a point it's too much, right?
Yeah, exactly. You don't want to worry too much about your sleep because that actually you develop performance anxiety about your sleep. So you want to make it a soothing place, but not go overboard with it, right? There's also the phenomenon that we call orthosomnia, which is now with all these wearable devices.
Yes.
You can get a lot of feedback.
Yes.
People track their sleep.
Yes.
Unfortunately, tracking your sleep does not improve your sleep, right? It's sort of good to have some feedback as how, what are the trends of your sleep, but they tend to produce more anxiety and induce more insomnia. Right?
So I had a patient today who has migraines, and he says, I'm a light sleeper, and he used his device to tell him that he's a light sleeper and got frustrated over that. So how accurate are these devices, or what are these devices telling you about sleep?
Yeah, it's good for trends. The more disrupted your sleep is, the less accurate they are, right? We know that they're relatively accurate for total sleep time. The sleep stages are not as accurate, particularly deep sleep, what we call the N3 sleep, and REM sleep. Those are the least accurate. They're about 70% accurate. That's what the studies have shown. So it can be a guide, particularly to look at trends over time. But most of the time, I have to talk to people about throwing the trackers away.
Right.
Because they're inducing more anxiety that they're actually helping.
So let me ask you a question about sleep. So how do you know you have quality sleep? Is the definition of quality sleep through a sleep study? When you say somebody had quality sleep, this person has efficient sleep, this is the maximum sleep, what is it you're looking at in a sleep study within the stages of sleep?
So in a sleep study, remember, a sleep study is a very foreign experience.
Yes.
So we're really looking for pathology.
Okay.
Right? Primarily sleep apnea.
Okay.
And sometimes people move their legs. We don't look at the stages of sleep because it's a foreign place.
Yes.
You're wearing all of this stuff.
Yes.
It's super uncomfortable.
Yes.
Right? It might be the worst night of sleep you ever had.
Right.
So we don't put much importance into the stages of sleep. Now,
Gotcha.
what we do want to see is that there are some breathing issues, like I was mentioning before, that get worse during certain stages. So we do want to look at your breathing in the different stages of sleep. Okay. But a single night of a sleep study, we don't really put much importance into the actual staging. As you know, sleep is dynamic. We all have good nights and bad nights. So the more you test, the more you track someone's sleep over time, the more representative it is of your home sleep, right? And that's where the tracking devices are helpful, right? You can track someone's total sleep time over a couple of weeks and sort of see, are they really getting the amount of sleep that they say they are or that they think they are?
Right.
Right. I had a good friend of mine who's a surgeon at Sylvester, and he came to me just feeling very, very tired, and we had him track his sleep. He thought he was just getting 7 hours of sleep most nights, but in reality, he was getting like 5.5 hours of sleep most workday nights. So it can be helpful.
It can be helpful. So basically what we're telling everybody is that we're looking for a pathology like periodic limb movements or narcolepsy or whatever it is through a sleep study to make a diagnosis. But it's not a study to say whether you're efficient of sleep, and this is not a score like you scored 100%, 80%.
No. We really work more on, other non-pathological sleep patterns, right? Like insufficient sleep, which is behaviorally insufficient sleep. Basically, that people may not prioritize their sleep at the end of the day. If you think about most of us, how we determine how many hours of sleep we get, you do all the things that you want to get done in the day. And whatever's left over is how much sleep you get.
Yep.
Right?
That's correct.
We prioritize things like our nutrition or going to the gym, but you don't prioritize your hours of sleep. And it's something that we should all do, because if you want to invest in wellness and keeping yourself healthy, that's like a huge return on your investment.
Okay. So not children, because we can move to children, but in adults, what is the best time to sleep? Like, let's say human growth hormone or BDNF or all of these things that help us heal or help download our memory. What time is the best time to go to sleep?
Well, you have to listen to your body, right? We all have
different.
We all have a chronotype preference.
Okay.
Right? We've heard that people are morning larks or night owls, right? That can be genetic in some families. The normal evolution, though, is as we get older, in youth, we tend to be night owls, right? We have what's called a delayed sleep phase, right? And it's that way through our 20s, right? In older age, usually after the age of 40, 50, most people become morning larks. You start becoming a morning person, right? So there's a whole evolution of how your sleep changes as you age.
I definitely see that in adults, especially my elderly patients wake up earlier. I tend to wake up earlier not because it's quieter. I feel more efficient. I get excited. I also, in a way, I want to slow down time a little bit. So I want to enjoy the day. So I do tend to go to sleep a little earlier, but I really want to enjoy the day. Now let's get into napping. Okay. Yes. I love napping, although I could tell you that if I do nap, it's going to interfere with my sleep. But on the weekends, it's like, yes, if I have a chance to nap. What do you say? There's two things about napping that I found interesting. One is napping. Like, are you against napping? And number two is, how long can someone nap for? That does not interfere with their sleep, that might give them a boost.
Yeah. I think in general, napping could be a good idea, particularly short napping. Usually time napping is what we recommend, 15, 20, 25 minutes power naps. If you have to nap too often, though, during the day, it might indicate that there's something wrong with your nighttime sleep. Right. So it can be a proxy for there's something going on with your sleep, right? So it depends on how often you have to nap and how long it's for. So you don't want it to be too long.
Is there a time of the day where you say no napping?
Well, we all have a circadian dip post-lunch, right?
Okay.
Which is usually like between 2 and 4. Our circadian drive is low. So we all get that post-lunch kind of coma feeling. So you can nap in that interval.
Siesta.
Yeah.
So the Europeans got it right. We should do that here in Miami, no?
We should. I'm a big proponent of that.
The problem is I won't go back to work. All right. So siesta. So I feel that sometimes if you take that nap a little later on in the day, though, that might interfere with your sleep. Now, there's this thing, what's it called? An espresso nap or?
Yes.
Okay. Right. So what is this new fad that I was talking about?
Yeah, it's been around for a while. We sometimes use it in people who are overnight shift workers, right? Okay. So people who work nights and then come home early in the morning. Usually they go to bed at like 8 a.m. They sleep until about lunchtime. So maybe they got 4 hours of sleep. They wake up, have lunch, and then maybe have another 2-hour nap before they go to their nighttime shift again. You can use this espresso nap, which is basically drinking a cup of coffee, taking a nap that's usually about 30 minutes. And when you wake up, the caffeine is sort of kicking in. So when you wake up, you're really alert.
And so is that healthy, or would you say that's unhealthy, or it depends on the time?
I mean, most people who sometimes work overnight can really struggle with sleepiness at night, with a lot of cognitive issues too. So sometimes we use stimulants in those people because you just don't sleep as well during the day. We're not really meant to be day sleepers, right? So they do use a lot of caffeine to stay awake, or even sometimes prescribe stimulants like modafinil.
Okay, so let me get to alcohol. So let's say alcohol makes people sleepy, right? If I drink red wine, it'll make me tired and feel sleepy. Yeah. People think that is that a sleep aid. They feel like drinking later on in the day will calm them, make them feel less anxious. Is that helping them sleep?
No, it actually, once you metabolize that alcohol, actually causes you to wake up. So though initially it puts you down, it actually fragments your sleep. You get much lighter sleep with alcohol. So that is one of the things that we always have to take away from people if they're open to it, because it's very, very harmful.
Does it depend on how much alcohol?
To tell you the truth, no alcohol is good for your sleep. So when I have a drink, I know that my sleep is much worse than it might usually be.
All right. And how about let's get into the prescription, which is what you gave me. I think the prescription is everything you said today. To all the knowledge is the prescription. Although we have to kind of get into medications on what patients say are prescriptions. Because I say what my prescriptions usually is a strategy and it's education. So when do you decide that, you know what, it's time for a medication on a patient that has, let me just describe the patient, is the patient that says, you know what, doc, I've gone through these changes, even though you probably question them as far as the hygiene. Let's say they're anxious, they can't shut their brain off, they're not sleeping well, they're not performing. What do you decide on a medication for that patient?
Yeah, one of the interesting things about working in a sleep clinic is that there's a lot of mental health presentations that we get in a sleep clinic, and a patient may come to a sleep clinic but may not go to a psychiatrist or a psychologist because of the stigma around those issues.
Yes.
So we do have the opportunity to sometimes intervene with these presentations. And we can often prescribe like a sedating antidepressant or anxiolytic to perhaps take care of that mental health issue that's driving the insomnia. We often have that discussion that, I'd like for you to also speak to a mental health expert if that patient is open to it, but sometimes they may or may not be.
So that's the question I have is let's talk with like a benzodiazepine, like alprazolam or clonazepam or diazepam or whatever the choice is. I have patients that say I don't want to get addicted to it, yet they're asking for it. And then I have the second patients also that are telling me that they're fearful that these drugs are associated with dementia. So just I'm throwing those things out. What do you say to patients that say are asking for it, but yet they don't want to be addicted? How do you approach a patient? Or when do you choose a benzodiazepine, if you do?
I don't prescribe benzodiazepines for sleep.
Amazing.
They're terrible for your brain. It is associated with dementia. It's associated with higher mortality. So if anything, I have to talk to people of how are we going to take you off of these medications, which is a lot more work. But, it's a slippery slope when we're prescribing sleep aids for people, because not only do patients develop physical dependence on some of these medications, but there's a huge psychological dependence on medications, because now a patient may believe that I need a medication to sleep, which is actually not true.
Right. Safety. Right. So one of the things I talk about with anxiety is the dependency on a safety tool or safety object.
Right.
So they're saying, look, I need that medication. Without that, I can't sleep. But then I get patients that say, you know what, I'm 70 years old. I'm not going to change. So I'm not changing my mind, not changing my brain. I need a medication. So how do you approach a patient like that? You go.
I think that we have a discussion about that. I don't usually prescribe a lot of sleep aids, but there are some people who want that, right?
But isn't it amazing that you're a sleep specialist, right? And you've gone in detail of so many things about sleep, yet the doctors that are not sleep specialists, which I love them, I work with them, is that they're prescribing these medications and you're a sleep specialist taking them off these medications. Don't you think that's kind of strange?
Yes.
Yes.
But what I do takes a lot of time.
Yes.
And talking to people for
Yes.
a long time, it's
Yes.
very invested. It
Yes.
is like life coaching. We go through their whole life.
Yes.
And it, you know, luckily where I work, I am devoted to spend that much time with patients. I don't know. I know that the primary care physicians have 20 other things that they
Yes.
need to deal with,
Yes.
right? But they do see the bulk of sleep complaints, and
Yes.
they do the bulk of prescribing of sedative hypnotics.
Yeah, so like you asked me what's the healthy mind about, and you say you act like a life coach, and yes, I am a life coach. I have changed the way I practice medicine for you and I can really nerd it out together with all the neurology, all the differential diagnoses. We can treat all these conditions that are so rare, or even the ones that are medical, yet when it comes to patients that really come in our office, it's all about habitary change, habits, education, and really getting into their life, because the symptoms that are just like this of insomnia is just there's so many different types of pillars that are so important, correct? So I become a life coach with mind, body, brain, pretty much education.
Yeah. I mean, I think also making some of these changes, though, it's a bit of a luxury, right?
Yeah.
Because we look at things like when you sleep, where you sleep, who you sleep with. You know, these are all proxies sometimes for socioeconomic status. I'll tell you, like this past week, I spoke to this amazing lady who was having a lot of insomnia, and part of that insomnia that she had was that her and her husband had a very different work schedule. So he had to wake up at 4:00 in the morning, and then he would wake her up, and she basically couldn't get back to sleep. So we kind of talked about different strategies of what we could use. And something that we settled about was something that we called sleep divorce, which is people sleeping in separate bedrooms.
That's a new thing, I think. I've seen that.
Yes
if
and
you have
no.
the luxury to have 2 bedrooms.
The luxury to have another bedroom to actually go in and sleep. You know that 40% of couples in the U.S. sleep in separate bedrooms?
That's a very large number.
It is.
Is it from snoring, or
I don't have the specifics.
or they
of
just
that.
hate each other after a while?
No comment.
Okay, so let's continue the patient that we're talking about, medication and sleep. And so we said that maybe we don't give those type of drugs. So again, when do you choose to do? Is there a group of drugs that have come out?
Yeah, so there's some newer medications that seem to be less harmful, like the DORAs, the dual orexin receptor agonists.
Okay.
Right? There's a new kind of medications which used a lot of what we know about narcolepsy, which are people who are very, very sleepy, right? That looked at the pathology, and drug makers basically were able to make a medication to create a narcolepsy-like
drug,
right? To induce for people who have chronic insomnia, right? So those medications seem to have less side effects associated with them. Most sleep medications, what they do is that if you think of sleepiness and wakefulness as a seesaw, most sleep medications put more weight into the sleepiness promoting centers of the brain. So they make you sleepier. The DORAs, this other types of medications, actually turn down the volume on the wakefulness centers of the brain. So they don't cause as much hangover effect.
This is what I was going to ask you too, and I think it's important to understand is that when patients are not from you but other doctors or whatever, we prescribe medications that tell them that help them sleep at night. Let's say benzos or whatever. Are they actually getting the stages of sleep? They say they are. So now they go on a medication. This is a big myth, right?
Yeah.
They go on a medication and say, I'm taking this medication and now I'm sleeping.
Yeah.
Is it possible that they're really not sleeping?
Well, we know
efficiently?
We know that benzos, for example, one of the things that they do is suppress your slow wave sleep, or the very deep part of sleep. And that slow wave sleep has some very important physiological functions, like the releasing growth hormone, for example. So it does have a negative effect on your physiology. So if anything, it shifts your sleep stages from deeper to lighter.
How about like Ambien, Zolpidem? Are you actually sleeping, or is it tricking your brain that you're sleeping?
Well, they don't do as much of that shift as a typical benzos do.
Okay.
Right? So they have a better side effect profile, but you do have to wonder why you're having to take the sleep medication in the first place.
That's correct. That's correct. One thing that interests me about sleep also is I feel like we were talking about before, back into the cognitive, because it's such a big part, is I feel like sleep is safety and security. And when you feel safe and secure, you sleep better.
Yeah.
I've seen weighted blankets. And
Yes.
Do you feel do you teach people how to be safe and secure in their environment? Do you also talk about, do weighted blankets help?
Yeah. So that's a very important point. Like even neighborhoods, right, have a very important impact on your sleep.
Okay.
If you feel safe in your neighborhood, if you feel safe where you're sleeping, who you sleep with, that has a very important impact on your sleep. For example, caregiving is a very common situation that can impact people's sleep, very similar to being on call, right? When you're caregiving for maybe an elderly parent or for a special needs kids, your brain may not be able to fully go into a deep sleep because anything could happen in the middle of the night.
Yes.
So you have a much, much lighter sleep. And we've done a lot of neuroimaging studies showing that the amygdala and those centers are actually activated in patients who have to provide caregiving duties in the middle of the night.
That's right.
Yeah.
I think that, and I definitely see that, and I see that they're very much sleep deprived. Let's get into the over-the-counter stuff that I see in practice, and people think that it helps. So, but one of them is not over. Let's talk about, this is a big thing. I talked about it before, but I really want to hear from a sleep specialist about melatonin. How much melatonin, when to take melatonin.
Yeah.
What is the indication for melatonin?
Right.
So
so
what's the function of
melatonin is
melatonin?
tricky.
Yes.
Melatonin has sort of two functions. One is for phase shifting, or sort of changing the times when you feel sleepy. And what most people use it for is a hypnotic, right? Taking it right before bed.
Yes.
The American Academy of Sleep Medicine does not recommend it for
That's
the
correct.
treatment of chronic insomnia, right? We mostly use it for people who have work shift disorder or jet lag or things like that, or these delayed sleep phases to shift your underlying biological clock by a few hours, but it has to be given at the correct time. Okay, so for example, for people who fall asleep, let's say at 2 or 3 o'clock in the morning, you can take a very small dose of melatonin, usually 0.5 milligram, which is the physiological amount, 6 hours prior.
6 hours prior.
Yeah, so it has to be timed, right?
So that's the question. So I recommend, I usually tell my patients a 0.5, maximum 1 milligram, 4 to 6 hours to desired sleep.
That's
how about so let's see what the indications for people that actually do travel from West Coast to East Coast to West Coast or vice versa. Just briefly, I know this is how do you, that's the thing is people, how do they know when to take it?
That's actually really complicated.
It is complicated. So is there an app or way for people to calculate?
There are apps that basically where you can basically putting yourself into the new sleep time of the week before you go.
Okay.
So you kind of start to shift by an hour a day into the new schedule that you're going into.
Now, the other question about melatonin is, like, when you go to like a pharmacy or a supermarket, the melatonin, if they actually measure the synthetic melatonin, it actually varies. Is there a specific, not brand, but like somewhere so a patient can look and say, this is the real melatonin that I'm getting? Or anything specific?
You have to go to a large pharmaceutical brand that looks at quality.
Okay.
Right? Unfortunately, in the US, it's not FDA controlled. In many other countries, like in Europe, in Latin America, in Israel, it's actually prescribed. And you know exactly how much you're taking.
Interesting. How about so the next step is after melatonin, I see antihistamines, Benadryls or the PMs at the end of it.
Yeah.
Those
are
or
terrible.
hydroxyzine that they use, but that's prescribed. Did you say terrible?
Yeah.
Okay. Why is it terrible?
It just makes people extremely groggy. We don't really use those, and we don't recommend those.
It's because of the the medication half-life, or how long it lasts? It goes,
Yeah.
Okay. So,
Sorry, I never answered your question about weighted blankets.
yes, let's
Yeah.
go back.
So,
Thank you.
So the weighted blankets can help. Particularly, the studies have been done in people who have a lot of anxiety, anxiety and insomnia. There is some literature showing that they can be beneficial. So usually, if you're going to get a weighted blanket, it has to be 10% of your body weight. So
10% of your body weight.
yeah,
Okay.
if you're 100 pounds, it has to be about 10 pounds. It takes a little bit of getting used to because you can feel a little smothered at the beginning. But the basic idea is that it activates your pressure points and activates your parasympathetic system to calm you down. Very similar to the jackets with the pets that freak out with the lightning.
So it's a sense of safety and security that I think.
Yeah.
So this is another question I have. This is more back to the cognitive behavioral, and this is what I see a lot of my practice and a lot of patients is when they're in the bed, okay, and they're not. I know you got to get into the root of why they're not sleeping.
Yeah.
And they're looking at that clock.
Yes.
What's the recommendation of waking up after an hour and seeing the clock, being in bed, restless, the brain is just talking to you? How do you...
so this is what we call stimulus control, which is basically stop the watching, right? I like to tell people to even leave their phones outside of the bedroom, or definitely not at arm's reach, because a lot of people just grab for the phone, start scrolling, right? Doom scrolling in the middle of the night. We tell them if you can't fall back to sleep within 20 minutes, you have to physically remove yourself from the bed and sort of do something kind of more boring. Listen to music, listen to an audible until you feel sleepy, and then you return to bed. So you have to reteach your mind to make the association of the bedroom with sleepiness. That means waiting until you feel sleepy and then going to bed, not laying in bed, tossing and turning, frustrating, unable to fall back to sleep, because that doesn't help.
And that's a huge, I mean, if anyone's listening to this, I think this is one of the biggest things that I see is that they wake up and then it's looking at the clock and then thinking about the next day, what they need to do, why they can't sleep at night. And then when I tell some of my patients, you need to get out and, maybe read something really like a history or something that's going to calm you, or listen to something that's going to calm you. Nothing exciting, right? They don't want to, a lot of them don't want to do it. They think so that's the thing.
It's too much work.
It's too much work.
Yeah. Well, I always sort of go back to, this is for your health, right? And you're telling me you don't want to use medications.
Right.
So this is actually how we manage insomnia. It is really difficult. It is.
It is, right.
But you have to be disciplined.
And you have to be disciplined, just like the gym, going to the gym. And it's all about habits. Don't you think habits is a huge part? I talk about habits. I think the subconscious talks about habits. I said before we started, I said even sleeping on the right side, left side, the time you go to bed, what time you exercise before bed or that day, whatever it is, it's all habits. Everything, the way your subconscious and your autopilot brain does is through habits.
I mean, I always sort of challenge people, particularly those that are invested in wellness, right? They invest so much in supplements, their gym, their nutrition, but sometimes they don't want to invest in their sleep.
No, right.
And they think like the problem with sleep issues, particularly when you were a good sleeper prior, is that then you have to work at it. So people feel really burdened because they already have a gazillion things to do, and now you're telling me that I have to do all these other things to fix my sleep.
Right.
But it's worth it, right?
Well,
it's for your brain health.
Well, I find also people that are like take care of themselves at the gym, or they eat so clean, and they're like so over the top that their brains also can't shut off where they can relax and fall asleep, and they just ignore the part of the sleep function. But back to athletes, and this is something that I find fascinating, is that LeBron James really, like, people look at LeBron James, look at his frame and say, oh, LeBron James is this big and he doesn't, well, yes, he puts the work and the effort into it. They don't really look at his habits with his nutrition and his sleep. He sleeps, I don't know if you've, I've read 10 to 12 hours. He takes several naps. He really takes care of sleep, which is part of the human growth recovery. I think it's extremely important. Don't you think that should be part of athletes, is looking at their sleep? Because
Many professional teams have sleep coaches. They do have sleep consultants.
But a lot of these young guys will go out at night, they'll visit the city, they'll party, and they expect to perform the next day.
Right.
I think LeBron himself really prioritizes sleep. And I think that's one of the reasons why he is getting to his age and still being at really at high physical level, high performance level. But let's get back just very quickly is that, we kind of said it in the beginning, but it's to me, it's the stigma of that insomnia is just part of life. I mean, that's what people think, really, that it's okay to be sleep deprived, because if you're sleeping, you're not really getting things done. Is that correct?
Yeah. So a lot of people, it's part of the hustle culture, right? Like achieving a lot. Sometimes that can really work against you in terms of your health, right?
Sure.
I sometimes see this with people who own their own businesses, right? They kind of work late into the night, and then they sort of wonder why I can't fall back to sleep or I can't fall asleep quickly, because they're very active in terms of like managing their business and perhaps carry that whole daytime stress late into the night, and then sort of get frustrated when they're not able to just automatically turn off,
I think I'm more efficient, with sleeping more, and then my efficiency with my cognitive function. I definitely know that I'm work much better and more efficient when I sleep well.
Yeah, there's some people who need
more sleep.
A wind down routine too, right? Because
I was gonna get into a little bit of
people need like a prolonged wind down routine. Some people may need a more prolonged wind down routine than others, right? Depending on the amount of stress or activity that you have in your life.
All right, so let's get into that little wind down. I know we're bouncing back and forth, but these are so many things that I think a lot of people are very interested in is the wind down routine in the bed, the TV.
Yeah, so one of the things I usually ask people is, okay, tell me what time you have dinner. Tell me like what happens like around your dinner schedule.
This is great.
Right? What happens? What do you guys do after dinner? And what happens after that, right? So usually people have some sort of semi-routine, but you can tell that some people's
habits
and nighttime is quite irregular, very variable. So it's not surprising that their sleep is also quite variable. So we do kind of have to talk about sort of organizing your nighttime sort of habits and sequences. It does take some planning, right? It does sort of, I don't want to say kills the joy of being impulsive or spontaneous.
Sure.
But it is sort of part of grabbing control of your sleep, right? Grabbing control of that sleep routine.
But the TV itself, so that you've done dinner. Now, so let's say it's dinner, about food. Let's talk quickly about food. There's so much to talk about. So let's say you have dinner. Is there a time having dinner too late will affect sleep?
I mean, we usually recommend that you don't have dinner 3 to 4 hours prior to bed. So you definitely don't want to have a huge meal, right? Like full of fat.
And how about
that will sort of
affect your
give
digestion?
You reflux and a lot of other things.
And how about sugar? A little sugar, a little dessert.
Yeah, I mean, I do love dessert.
Yeah, but human. Yes.
But I can tell you that I'm super sensitive to like chocolate.
Sure.
And I won't sleep. So,
you won't sleep, so sugar affects sleep as well.
Yeah, for
okay.
Sure.
And then back to the TV. So because that's a huge thing in my house. I
think also
my wife
people
loves
have
the TV.
People have to talk about like what they like to watch. Right?
Sure.
Because I think the content really sets your mind frame for the night. Right?
Well, it's what I say is like when people go to a spa, and they walk in, their brain already programs themselves. They're going to a spa.
Right.
Are you going to put a scary movie horror at a spa? No. So then why are you doing that to yourself at night? Why are you putting these things on TV at night? I think people are addicted to the bias of fear and the storylines that are going on in the world, and they really feed off of it. I think it's an addiction.
Yeah, definitely getting in the right mind frame before you go to bed is super important, because this is actually what gets into your dreams, right?
Yeah, so we're going to get to dreams last. Yes.
Right? Most of us sort of dream about our everyday things.
Sure.
Usually the last things that you're thinking about, that you're exposed to, is what actually permeates your dreams and your nightmares.
I think our brains are so, or information overload, that it brings it to the bedroom, obviously, and then there's so much social media that people bring into the bedroom. I think sex is down. I think that intimacy is down. I think and sleep is down. I think there's so much, and unfortunately, what happens to me is that I feel like my day, I work hard during the day, like you do, but then I sometimes get home late, and I'm like, you know what? If I sleep, then my next day is back to work. Right. Let me enjoy the night more. Let me have some freedom. Let me watch a football game.
Yeah, that's actually what a lot of people do, which is really interesting, right? They take care of all their daily activities. People who have children have to put them down, get them all ready for bed. And then it's me time. Right. And then they sort of get themselves whatever they like to do at night, whether that's reading a book or catching up on their Netflix show. The problem is that often happens at the sleep suffers. That comes at the cost of their sleep hours, right? So it's this whole thing about making this trade-off between your sleep times and also giving yourself a treat, right? Maybe not doing every single night of the week, but maybe cutting it down to a couple times a week. Sometimes we have to strike contracts with people or find a balance, right? Of what maybe I want them to do, what they want to do.
I just the epidemic of insomnia and sleep difficulties is at its worst, and I think it's going to continue just as much as it parallels with anxiety, because our brains are information overload. We just want more information, and I talk about it. Is that boredom, or even meditating, or being okay with really nothing of thoughts, no thoughts, having a clear mind is very infrequent these days.
So talking about that, though, you'd be surprised just from looking at sleep studies how many people sleep with their phones next to their head on the bed, and how often sometimes they get calls in the middle of the night, or they just reach for their phone or start scrolling at 2 or 3 o'clock in the morning
without being aware.
No, they're awake.
Oh, they're awake.
They're awake.
Okay, they're awake.
But it's
part of it.
It's part of it.
It's part of it.
So
waking
addictive.
Up. It's a pacifier.
It's
a baby waking up and giving them the pacifier.
Yeah. Right
back to bed. And that's part. As a doctor, I have to keep the cell phone next to me.
That's different.
I know. But if I go on vacation and there's no TV and I don't need to my cell phone, it is fantastic. Let's get into dreams. I think that's so fascinating. Well, your specialty is sleep, right? And you're at the VA, which is veterans and post-traumatic. That's a whole topic in itself. Well, we're going to invite you back because you're awesome.
That's a whole other session.
Yeah, that's a whole set. And especially the dreams itself and the analyzation of dreams. Don't you find it fascinating how much we don't know about dreams?
Yeah, for sure. I mean, they are tightly linked to creativity, right? So it is where we kind of work out some of our problems in our sleep, and sometimes come up with the great solutions, right? They've done some really interesting studies out of Harvard with just this very famous gentleman, Robert Stickgold, who back in the day when they had Tetris, remember?
Of course.
They used to have patients play Tetris before bed.
Okay.
And then they would wake them up in subsequent sleep cycles while patients were dreaming. And they would ask people, hey, what were you dreaming about? And the deeper they got into their sleep cycles and further into their REM cycles, those very concrete images of the columns coming down would get integrated into those dreams. So at first they would say things like, oh, I saw maybe a concrete column or a building with concrete columns. And the later in the night it got, the more abstract those initial ideas got. In the next REM cycle, maybe now there were trees and the person was skiing through the trees. So it's really interesting. It's
so interesting because your brain is really downloading the information through the day, and it typically downloads at night. Like I know when I used to study for tests and stuff, I'll be dreaming about all these, from medical school, these body parts coming in. And it was freaking me out, and I'd wake up earlier to study again. And it just shows you how important the night routine before you go to sleep, how important it is to have something very peaceful and calm, right?
Right.
And what do you think about dream analysis?
Well, we
not you,
really
not you, but just in
much
general.
of that.
Just but the interest about it. Obviously, it is very controversial, but also it's interesting. What do you feel about it? Just as a regular person, non-doctor, let's say, take off the doctor.
I mean, many people come to the clinic and tell me about their dreams, and you know, we kind of talk about potential meanings, but most of the time I just tell them that it's common everyday kind of gibberish that gets integrated into your thoughts, right? So people want to ascribe significance to that, right? And they can if they want to, but I don't really have much of a, I don't really comment one way or the other.
Right. You just listen to them.
I listen to them, and
that's pretty interesting.
Yeah.
Right.
Usually we all have a good laugh, right? There is, for people who have distressing dreams, right? Things like nightmares.
Yes. Post-traumatic stress disorder.
That are recurring nightmares with the same themes, right? There is something called image rehearsal therapy, which the idea is that if you have a common nightmare, you basically keep a dream journal, and you can essentially write a new ending to that very distressing dream, and you read yourself sort of that new storyline to your dream, and in that way you can actually change your dream.
You can change your dream. Very interesting. So you talked a little bit about mindfulness. So how do you bring mindfulness into insomnia or approach to patients that have sleep disorders?
Yeah, we know that mindfulness is one of the strategies that can help a lot with chronic insomnia. So it is something I recommend regularly to patients.
So I think mindfulness is two steps. One is mindfulness is becoming mindful, noticing. So everything you discussed about educating and noticing all of these sleep hygienes about the bed is for sleep and sex and maybe really sickness. Those are very much strategies where your brain starts to notice. And then the mindfulness practice of meditation, or even getting into, I typically do myself, is progressive muscle relaxation.
Yep.
And when I lay down in that bed, I know that it's like time to go to sleep, and I am enjoying my bed, and I'm out within seconds.
So many protocols for cognitive behavioral therapy actually incorporate mindfulness into it as well.
All right, how about snoring? So there's so much about snoring, but we're going to get into just the specifics. I'll bring you back into obstructive sleep apnea itself. So what is it, the myths about snoring? Is it basically the neck itself? Women snore too. So let's talk about just about snoring. What's your approach to snoring?
So it depends, right? Loud snoring with witnessed apnea. It's like someone sees you stop breathing in your sleep. That usually is a surefire you have sleep apnea to some degree. Okay. Now, obviously, everyone can snore given the right conditions, right? Either maybe you drank a few beers, you're sleeping flat on your back, that will promote snoring. Maybe you had a really physically exhausting day.
Yes.
We really start to worry about sleep apnea when it's habitual snoring. You snore most days of the week. You have witnessed apneas, and you're waking up in the morning feeling unrefreshed despite getting an adequate amount of sleep. Mm-hmm. So that's where we start to really kind of worry about sleep apnea. Now, for women, particularly younger women, premenopausal women, they don't snore very much. So symptoms of sleep apnea in women tend to be much more subtle. They present more with insomnia complaints, and they tend to be almost like heavy breathers, right? What happens to postmenopausal women because of the loss of hormones, now they tend to snore more. So they have equivalent risks for sleep apnea as men, postmenopausal women do.
Interesting. We have to go to very briefly on menopause because that's a big topic in my office, specifically my migraine patients. We'll talk a little bit about menopause and sleep. I mean, we could talk a long time about that, but just briefly. But let's get back into the snoring. So, when is it, or who should get a sleep study in general when it comes to snoring? So you just mentioned those terms, right? But let's say a patient does get let's say they have lack of sleep, where they feel tired in the morning, where they feel groggy. Yep. There is a Epworth score. Sleep is that you go by that standard, or
right?
Describe that a little bit about the Epworth sleepiness scale.
So the Epworth is basically the propensity, how likely you are to fall asleep in everyday common situations. Things like after you have lunch without alcohol, as a passenger in a car,
Yes.
While reading a book, while watching TV. And this gives us a general idea of how sleepy you might perceive to be. Having said that, sometimes it's not a great scale for measuring sleepiness. There's many people who will literally fall asleep right in front of you, and they will report no sleepiness, right? So there are some caveats, right? It's more important to look at things like functional sleepiness. Do you fall asleep during your day if you're doing something boring? That's usually what I ask people,
But this is the question I have to you, and this is something that we kind of brought up, is there a difference between people that can't, because what happens, I have a lot of patients that say they have obstructive sleep apnea, and that's the reason why they have insomnia. Yet,
so there's actually a special condition, which we call comorbid insomnia and sleep apnea. It's actually called COMISA. Comorbid insomnia and obstructive sleep apnea. About 40 to 50% of people who come to our sleep clinic actually have both things.
Right.
And those two sleep problems, sometimes they get confused.
Absolutely. I think patients do get confused. The patients say that, I can't sleep at night because I have sleep apnea.
Right. No.
And they're, right.
They just you have two separate conditions that need two separate treatments.
And what are the treatments for sleep apnea, just in general?
So for people who are overweight, losing weight,
okay,
right, we look at environmental things like how much alcohol you have. So we try to decrease that or eliminate that if possible. Then we can look at things like allergens. Do you have a lot of nasal congestion? Do you have a lot of environmental or allergen exposure? So maybe you need some antihistamine kind of treatment for that specifically. For people who have moderate to severe sleep apnea, we do use CPAP, which is first-line treatment, which is a device that gives you pressurized air through a small mask. And that air works as an air splint. It takes the soft tissues in the back part of your throat that collapse while you sleep, and it gently pushes them open. Now, adherence to positive airway pressure or CPAP is not great. Some people really hate it. For people who cannot tolerate that treatment, sometimes you can go to a dentist and get something called a mandibular advancement device, which is a oral appliance which keeps your jaw forward. Mm-hmm. And by moving your jaw forward during the night, it opens up your airway and it decreases the snoring. And that's FDA approved for people who have mild to moderate sleep apnea. Now, there are some surgical interventions also where ears, nose, and throat doctor goes in and removes some of the soft tissues. And now there's an implant called hypoglossal nerve stimulation, right? You guys may have seen the Inspire commercials.
Yes, of course.
And this is a device that you turn on at night when you're going to go to sleep, and it gives your tongue tone so that it doesn't flop backwards when you're taking a breath in. So the whole night, your tongue is moving forward so that it doesn't create the apnea. And finally, there are the weight loss medications, specifically tirzepatide, that recently got FDA approval for people who have moderate to severe sleep apnea.
Interesting.
And who are obese.
So weight loss, modifications, and then devices. What about these nasal strips? I see this and it's a big fad.
Those work really for people who have what we call primary snoring, people who snore primarily nasally, who maybe don't stop breathing in their sleep. Yeah, so that is another potential avenue.
So for sleep apnea plus insomnia, because I put them kind of somewhat together, but we can separate them. What are the health risks associated with sleep deficiency and or obstructive sleep apnea?
So having the combination of both disorders, as you can imagine, is worse than having each one alone. So you know that people who have both sleep apnea and chronic insomnia together, those people have higher risk for anxiety, depression, even mortality, development of high blood pressure, even diabetes. So it is a more dangerous or more burdensome sleep disorder to have, and it's a little bit more complicated to treat.
And atrial fibrillation as well?
Yeah, the studies haven't looked at cardiac arrhythmias as of yet, but having sleep apnea alone of course, increases your risk for atrial fibrillation. So yes.
Okay. How about cognitive impairments, that's a big one, right? So it's interesting because now we're in a phase which is good. We're in a preventative neurology.
Yeah.
I remember 15, 16 years ago when someone said, how do you prevent Alzheimer's? It was very hard to really understand Alzheimer's. As much we're learning now, it's an inflammatory condition. It's a condition that it's genetic. Some point there is a percentage, I've talked about this, but I say that the genetics are there, yet the genetics preload the gun. But what pulls the trigger is lifestyle and the way we sleep.
Yeah.
The way we think too. I just saw a study about negative thinking and increased risk of dementia. There's so many things. So diet, exercise, sleep. Since we're here about sleep, what are you teaching your patients about the link with Alzheimer's, dementia, and sleep deficiency or insomnia?
Right. So we do know that in certain stages of sleep, your brain normally has a system called the glymphatic system, right? Which is sort of the filtration, let's say, byproducts that the neurons, and specifically microglia, which are the supporting cells, they emit some of this, let's say, metabolic trash that has to be cleared by the glymphatic system. And that glymphatic system specifically is activated during slow wave sleep. So for people who are not getting sufficient sleep or not the right kind of sleep, this trash accumulates and we see more neurofibrillary tangles and more tau in the brains of patients who don't get appropriate levels of sleep.
So that shows you a direct link with Alzheimer's, dementia, and cognitive impairment, which makes sense, specifically if we can't activate that garbage delivery system of removing amyloid. How about movements before sleep? No, just in general, patients say that they can't keep their legs or they feel a restlessness. There is a condition, right?
Right.
But let's say separate to that, like a lot of patients say that they can't fall asleep and they say that they are restless but don't have restless leg syndrome, right? How do you differentiate the two just briefly and treatment options?
Right. So restless legs is usually a weird sensation that people get inside their legs typically. They can be described as creepy crawly. Sometimes patients have a very difficult time describing what it is. It is alleviated by movement, so getting up and walking around. It tends to be worse at night, but it can also happen during the day, particularly when you're immobilized. So maybe riding a plane, theater, where you have to sit still for a while. You feel like an inert restlessness that almost like something kind of tightening up, and you have to release that tension by walking about. It is more common in men than women. About 10% of the population can have it to some degree. It can run in families, particularly it's more common among people of Northern European background. That compared to, let's say, this kind of anxiousness that people can have with their legs. Sometimes people like to move their legs back and forth, right? There is something called a rhythmic movement disorder. That it's a normal variation. It's not something that necessarily needs to be treated, but some people also can rock. They can rock even from side to side, which is used as a soothing mechanism.
And sometimes patients also say that they kind of get a twitch before, right?
Yeah,
and
so we call those hypnic jerks, and that can be a normal variant. It usually can happen to you if you're particularly sleep deprived or if you're stressed. You have that jump.
It's happened to me before. And back to the restless leg. Do you screen for ferritin levels, anemia for RLS patients, restless legs? Okay.
So we ask things for women, obviously about menstruation. If you've had problems with lightheadedness, for example, like orthostasis, when getting lightheaded when you stand up, we might ask you about, colonoscopy. Have you had a colonoscopy recently? And there could be some medications that can aggravate your restless legs, antidepressants, for example, and antihistamines. Antihistamines like Benadryl, so it's a big one. So we take a good look at your medications. There can be other things that can produce restless like symptoms, like drinking too much caffeine during the day. Smoking and alcohol can also worsen the symptoms of restless legs.
Periodic limb movements, but just in general, isn't it amazing? Do people how much there's movement in sleep, right?
Yeah.
So isn't it fascinating to see how much we actually move around the bed while we're sleeping?
Yeah. Well, remember that moving during sleep is normal, right? So people tend to think that you need to sleep like a mummy that does not move the entire night. Sort of switching positions a bit during your sleep is a total normal phenomenon.
I'm going to bring this back again. So let me ask you a question. Some people have to go to the bathroom several times. Whatever. It's just in general. They maybe drink a lot of water before they go to bed. I have patients that say, you know what, after I get up, I can't go back to sleep. So it's the same thing, right? The same. How do they get back to sleep? Is there a specific, or you just go back to the same?
We do the easiest things first, right? We do look at like their liquid content, say early in the evening, but then you also may need to think about like, the prostate, right?
Yes.
They need to speak about the prostate
right.
issues with their urologist or their PCP, and they may need to take medication for that if that's an issue, right? But we also just, particularly as people get older, right, your sleep tends to fragment more.
Yes.
So you don't sleep in your 50s like you did when you were in your 20s, right? So having early morning awakenings becomes more and more normal as people get older. Right.
And people have to know that. And that's very interesting in itself. Now let's get into very quickly menopause. So a lot of patients, get into that age of 50 and any recommendations for menopausal stages where they get hot flashes and they also don't feel comfortable in bed and they have difficulty sleeping. What are some recommendations for patients that are in that phase of their life where they really have difficulty sleeping?
Yeah. So we still recommend the cognitive behavioral therapy for insomnia because that tends to be something that can really improve their sleep. But then I do often talk to them about considering HRT, right? And talking to their gynecologist because insomnia symptoms is one of the things that improves the most with hormone replacement therapy. So it is an important conversation to have with your gynecologist.
Very important because I think that also gets ignored. Some people say, oh, that's just part of also. Well, that's what happens too. It's like, okay, I can't sleep at night. That is part of the symptoms related. Let me just live with those symptoms. That is also a stigma. I just want to say that I really enjoyed this conversation. I learned a lot. But it's a good thing I am doing a lot of the things you're saying in my own life. And also I talk to my patients. And Dr. Wallace, I think I need to use this as an excuse to hang out with you more often.
Yes. I mean, I was thinking about this. I literally live 3 miles from you guys. And we never see each other. I know that you guys are busy and
or that's not an excuse. We are going to hang out because I see you.
We should hang out.
We just to understand that Dr. Wallace and we did our residency. I was 1 year, but he was one of my favorite residents to hang out with.
We spent a lot of fun times together.
We definitely fun times. One day we'll tell stories. Thank you so much for educating. It's so important. Part of this podcast is to really educate about sleep disorders, insomnia, health, mindfulness. I'm so happy that you're here. Thank you so much.
Yeah, no, thanks so much for inviting me.
Thank you.